Welcome everyone who's logging on today. I can do a little bit of housekeeping while people are getting logged on. So yeah, we're recording the session. It's set up as a meeting, not a webinar. So it would be great if, everyone can put themselves on mute until we get to the portion where we're going to have hopefully time for some Q&A. Of course, you can always also put your questions in the chat as we go along, and I can moderate them from there. Or after our OHT peer presenters speak, if we have time for a question or two, you can use the raise hand emoji and just unmute to ask your question. I think that's it for the housekeeping, Melissa. If you want to move to the intro slide. Yeah, so we're really excited to have our second community of practice meeting for cQIP today. And based on the polling that we did at the last meeting, this was a topic that people were interested in, talking about the process measures as part of the family of measures. So that's our topic for today. And we will go to the next slide, and I will do a land acknowledgement. So my name's Janine. I'm on the OHT implementation team. I help with cQIP, and I live in Peterborough. So I am an invited guest occupying the traditional Mishissagig Nishnabeg territory. Peterborough is on land associated with the Williams Treaty and the Rice Lake Treaty. And it's a city with many waterways, lakes, and rivers around it. It's part of the reason why I moved here. Also, of course, to be closer to my family. What's interesting is the Anishinaabe referred to this area or meeting place as Nogo Jiwanong, which means the place at the end of the rapids. But colonialists took the Anishinaabe name for the river, which is Odonabe, the river that beats like a heart, and they anglicized it to Otonabee River. So for those of you who may know Peterborough or the area, the Otonabee River sort of cuts right through the city, and we kind of have a west side and an east side to Peterborough. I think as part of the work towards decolonization, it's necessary to understand that we must not only take action towards working with Indigenous peoples, but also to work respectfully with the land. So I think about all the wonderful opportunities that I have in this area for hiking, fishing, cycling, kayaking. I feel very grateful. I really enjoy it. And I'm grateful for Indigenous people who have been stewards of the land. And thus I always try to sort of minimize my environmental footprint when I'm interacting with nature by, carpooling or packing out my garbage or helping with community cleanup days, whatever it may be. So yeah, that's my land acknowledgement. And I will put in the chat in case anyone's interested. I like to go to this website. It's called Whose Land. And if anyone wants to go there, there's an interactive map and you can see whose land you're on, as well as you can see what First Nations you might be living near. I live near Curve Lake First Nations. You can also see what residential schools might have been in your area. So just feel free. And if anyone wants to see and also put in the chat whose land they're on, you can feel free to do that. Okay. Thanks so much. Next slide, Melissa. So these are the objectives of the session today, which are really, I think for those of you who attended the last RISE session, you may have already been introduced to the model for improvement. So we're going to kind of jump off from that to talk about the family of measures. So we hope at the end you'll be able to understand the family measures a little bit more and sort of how they connect to each other and your overall aim statement. And we're going to also talk about a visual aid or tool you can use for this, which is called a driver diagram, or maybe you use a logic model. They're very similar. And we're going to hear from some OHT peers about the process measures they've been using, what worked and what didn't. Next slide. We're going to launch a poll now. If Melissa, if you can launch the poll, because we're just going to do a little poll at the start and the end to see if what we're talking about today improves your knowledge at all. So if you could select which statement best describes your understanding of what a process measure is. So either you understand what they are, you know how to use them and apply them, you know what they are, but you're not sure how to use and apply them, or you have no clue, which is fine. No judgment here. You can answer honestly. And we're going to redo at the end and see if anything changes after our talk today. So we'll just give that a few seconds, and you can let me know, Melissa, when it looks like we've got critical mass on the poll. Oh, someone else from Peterborough. That's great. We're good, Melissa? Okay. Great. Thanks so much. We'll go to the next slide, which I think is the agenda. Yeah, so we've done the top part. So we're going to be doing a little theory burst this morning. That'll be myself and Maggie Ford. And then we're going to have some great lessons from our OHT speakers, John, Kate, and Emily. And I think we're going to do wrap up. So they'll have 5 to 8 minutes each to present, with hopefully a couple of minutes for questions after each of those OHT presenters. And if we go to the next slide, oh, sorry, yeah. So these are our speakers today, and I'm going to let them sort of introduce themselves more formally when they go to do their chats. But we're really grateful that we have these wonderful volunteers who've agreed to come and talk about a little bit about their work. So we really appreciate that. And it's great to see the sharing going on. Okay, so let's get right into it. Again, if you attended the last RISE session, they did introduce this, the model for improvement. And sorry, I'm just pulling up my notes here. So the model for improvement asks 3 key questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? And the family of measures, or measurement for improvement, kind of fits in with that second question. How will we know that a change is an improvement? So how well is our system of interest performing? And here, when working on a QI project, you need some kind of objective, measurable feedback in real time from the interventions that you're planning to use. And so this is where the family of measures come in, where you would want to design an outcome. You probably have a process measure, and you will have PDSA measures, which are where you're collecting data on your tests of change to see if those changes are making a difference. For those of you maybe not familiar with the PDSA, that stands for Plan, Do, Study, Act. So when you have an aim and you come up with your change idea, you plan out the change idea, you do it. So you might try something new on one person, one patient, or one unit. You're going to study it, which means you're just looking to see, like, did that work or not? You might have feedback in the form of something you're measuring. It could be talking to the staff about how it went. And then the act is really like, did that work and we want to expand on this change idea? Did that not work and we're going to scrap it? Or are we going to tweak it slightly and try something a little bit different and go again? So I think you can go to the next slide, Melissa. So this is my garbage example related to the model for improvement. So in my household, there's a new rule in the township that we can only put out 2 bags of garbage, and we're a family of 6. So we have a lot more than 2 bags of garbage. We have at least 4, sometimes 5 bags of garbage. So we need to reduce our garbage by half. So that's my aim, is to reduce the garbage by half. So how will I know that it's working? Well, I'm going to count the number of bags, the number of garbage bags I'm putting out. I'm going to count them every week. And what changes can I make that will result in improvement? Well, I'm going to try to get my family to do the 3 R's, which is, we're going to maybe do some change ideas around reducing, reusing, or recycling. And in terms of the plan, do, study, act, like, what change idea do I want to test first? I think I'm going to test getting a green bin and getting my family to use the green bin. And I'm going to see if using the green bin over time is maybe actually going to affect that number of bags of garbage that I'm putting out every week. So that's just an example kind of like an aim and some change ideas and how the measures relate to the model for improvement. I wanted to use like a non-clinical example that we'll come back to throughout, just so we didn't get our minds kind of like stuck in the nitty-gritty of how something might actually happen in a clinical example. Okay, and I think I'm handing it over to you now, Maggie, to talk a little bit more about the family of measures.
Sounds good. Thanks, Janine. So welcome, everybody. So I'm going to talk a little bit about measures. So as probably this group knows, measurement is a critical part of knowing whether what you're doing is actually making a difference. And so it's really important to assess the impact of the changes, the impact of those changes, and if you've met your aim. So that's why we suggest using, and part of QI's common practice is using a set of measures to track change and learn over time across the different areas of the system or process, and it's really important. So think of, I really like this visual because it really, I think, demonstrates visually how this set of improvement measures are like a cog in a wheel. So they're all aligned and they're influencing the broad system aim, which here is visualized as the big dot. And the key here is really scaling your improvement down to what you can influence. And so I often hear from OHTs in the past where it's really hard. Sometimes it feels like you're boiling the ocean. You're trying to move this great big huge dot. And so if you focus on the big system measures, such as like access to mental health services, it's really important to identify those measures that are within your sphere of influence and that will have an indirect impact on that larger big dot that's at the system level. And so this is why it's important for leaders to identify this alignment of the effect at the macro level and then cascade it down to the micro level. So next slide, Melissa, we're going to go into a little bit more detail on how these measures are commonly used. So outcome measures. So these at a high level show how the system's working. Specifically, they look at the impact on your clients or patients. And the outcome measure is a result of your work. And so the outcome is influenced indirectly through the activities that humans or technology are doing. And so that's why process measures are key and why we wanted to really focus this session on process measures. So your process measures are focused on those tasks and activities and processes that, think of it as the humans are doing. So these are what's used for your PDSAs to test your change ideas, as Janine mentioned. They can act as a pulse check to understand whether your changes are having an impact, positive or negative, on the system. And also answering the question, are we on track in our efforts to improve the system? And so the process measure is a really important cog in this wheel, and it's the one where you have the most control and most effect on. The outcome measure will only move in the direction of improvement if the process measure is moving in the direction of interest. So these are really key. Balancing measures. So we don't, like as part of your cQIP, we don't ask you to collect them, but we do think as a good practice, it's good to have balancing measures. And we want you to be aware of these because often these are some of the unintended consequences. And it could be positive or negative, but we use these to see whether your design changes are having an impact on other parts of the system or causing new problems. And a few sort of last points here is we really want to emphasize that when you're selecting these measures, it's really critical to include the people whose lives are going to be impacted by the change. And so it's important to have their voice in deciding what's important from their perspective. And this could be your clients or it could be your providers. And the second point I wanted to make was around data stratification. So I know OHTs are very focused on segmentation. And this is, things like race, ethnicity, language, and it's an important strategy to show where there are potential systemic inequities and ensures that your improvement efforts are focused on closing those equity gaps. Next slide, Melissa. So now let's talk about a few of these examples. So let's take Janine's family again. So Her outcome measure is aligned to her overall aim of reducing garbage. So in this scenario, her outcome measure is the number of bags of garbage per week. Her process measure, so those PDSA tests of change, and she's going to be counting the number, or her family is going to be counting the number of blue bins at the curb. And then their balancing measure might be, what's the family experience of this additional work? You know, could be positive, could be negative. So now flipping it over to a clinical example from our cQIP, let's look at the outcome measure. So in this scenario, the outcome, which is aligned to the overall big dot issue of improving access to mental health and addiction care, our outcome measure is ED visit as first point of contact for mental health and related care. So while the outcome measure in this example is important, you know, what we would suggest is focus your efforts to moving the outcome measure with your process measure and those tasks and activities that people are doing. So the process measures. And so this might be things like, you know, measuring the number of client or counting the number of clients who are seen in a virtual care mental health program as an example. This is something that people can influence. This is where your PDSA small tests of change need to occur. And again, as Janine mentioned earlier, you're doing tests on a small scale first. You're assessing how well is it going before you continue to expand that particular initiative. And you may, you know, this is where it's okay to make a mistake. If you do something on a small scale and you're not getting the intended consequence, then that's where you can pivot to something else. And then the third example here for your balancing measure. So you might want to measure whether the client's needs are met. And again, this is looking for any unintended consequences, positive or negative. Next slide, please, Melissa. So I wanted to bring it back to many of you who are interacting with the QIP Navigator. Wanted to just show you that the work plan that you're submitting to us for your cQIP is also aligned to the model for improvement. But what I want to focus your attention on here is we do have in your change initiative section, we do ask for process measures. And this is where, you know, sometimes when we're reviewing them, sometimes there's opportunities where these can be a little bit more robust or improved. And so this is where we wanted to highlight that the purpose of having this here is to link these to your change ideas. So looking at how are you measuring your local tests of change? And this is a really key important to QI and why we wanted to sort of bring that here. So I think I'm handing it back over to you, Janine.
Yeah, that's great, Maggie. So now we're going to connect this to a visual tool called a driver diagram. So a driver diagram has three main components. It will have an aim or an outcome, which is your clearly defined goal, what you're trying to achieve. Primary drivers, they're linked to the aim. They're factors that are believed to have a direct impact on the aim, and then these secondary drivers. So I think it might be easier to explain, Melissa, if we go to the next slide, which shows the garbage example actually mocked up in a driver diagram. So yeah, you can see here that I've put the aim on the left. So your aim should be like a SMART goal for those of you who may have used those if you're former clinicians. So you want it to be kind of specific, measurable and time bound. And then those primary drivers, they can be broad. They do not necessarily need to be so specific, but they're the main factors that you believe are having a direct impact on the aim, or sometimes we call them your key leverage points. And then the next row is the secondary drivers. So they affect the primary drivers. And these are more specific areas where you're actually going to need to plan the changes for. So these are the things that we're going to need to address locally in order to achieve success. Okay, so they will then be the main processes where we are seeking to improve. And I mean, you can have as many columns as you want. Sometimes people have three, sometimes there's four. There can be multiple layers of drivers. And in the last row are the change ideas. So these are determined from your secondary drivers, and they're usually like very specific ideas for change that you then test and measure through the Plan, Do, Study, Act cycles, right? So think of those as like tangible pieces of work that are typically, as Maggie said, easier to complete or implement. You're going to test them, and then you're going to see, did they influence my secondary driver? And are they ultimately, does it look like they're maybe helping us to achieve the future desired state? So when you would read this driver diagram from left to right, you're going to see, you're going to learn how you're planning to achieve the aim. So you can see here also, I've attached measures to the driver diagram. So if you work together with your team to create this kind of visual aid, you can then go back and attach the measures to your driver diagram. But like, be strategic when you're thinking about measures, because obviously measuring everything comes at a cost of time and resources. So you're gonna, thanks Melissa, you're gonna like pick out the spots where you think it's important to have a measure so you can track what's going on in your system. And also remember, like in QI, everything is written in pencil. So if you create a driver diagram and have some change ideas and something's not working, or you need to change this, like, you can change it. It's just meant to be sort of a visual tool that helps in your communication with your partners and helps you kind of, it helps others kind of understand and see where things are going. So this is my garbage example where I've kind of mapped out, similar to from the model for improvement. You'll see I need to reduce the garbage. Really, I either need to like have less, need more capacity, or I need less demand. So I'm going to do the reduce, reuse, and recycle. And also maybe I'm going to do some education with my posters in the kitchen so the kids know what stuff's supposed to go in which bin. My change ideas are on the right about putting out the blue bins. And maybe I'm going to collect some data and share that with my family so they can be happy that we got some early wins and create some momentum there. And I've added in some of my measures there against my outcome, and also my process measures. So on the next slide, so that's basically a driver diagram, and we do have all these tools and templates available. We'll put the links in the chat after. So the next slide is actually an actual example from our All Nations OHT. I did get their permission to share this example. So they actually set a very exciting target to reduce their ALC by 10%. And I mocked up this driver diagram, but really, the primary drivers are the same. Either you have to increase supply or reduce demand for the space. And the secondary drivers that All Nations thought of was that they could share more information and resources. They could collaborate more with other healthcare partners in providing more coordinated care. And they could maybe provide feedback to all the team members on, what's happening in the system. And their change ideas were to set up an access and flow table that would meet regularly. They were going to work on expanding the number of specially trained practitioners in community paramedicine, sort of also expanding their scope. And they were going to collect and share data with staff on a number of solutions implemented. Now I put a couple of their process measures on there. So they were going to measure the number of solutions implemented and the number of meetings attended. But I wanted to put this out now to the group. Can anyone think of a different or other process measures that the All Nations OHT might want to use in relation to some of these change ideas? And there's no right or wrong. So I'm opening it to people to unmute themselves or put in the chat. What other process measures could they use in relation to their change ideas or secondary drivers? Don't be shy. Maybe I'll pick on Kate to see if she has an idea.
Maybe the type of, or the number of information and resources provided to certain type of organizations or providers. So you could do that in various ways, like number of newsletters or number of memos or whatever it is. I guess that would be one, I guess.
That's great. Thank you. There's some coming in the chat. So the number of net new providers trained, Yeah, the number of patients served within the expanded scope. I think that's a great one. One that I was thinking of in relation to the access and flow table, I feel like number of meetings attended is great, but I might want to know the proportion. Like if you knew how many partners you wanted at the table, I might want to track how many times or how often did all the partners show up at the table, right? Because if the idea with the table is to help promote the collaboration of the healthcare partners, it won't work if 80% of the time only two people show up, right? So I'd want to know like how I might want to track how many partners were represented at the table or something like that. But yeah, we've got some ideas in the chat. Yeah, so that's great. So all to say there's no right or wrong, like depending on what your priorities are, what kind of digging you've done around like what the true problem or root cause of your issues are, you may have different change ideas and you may find it important to, track different things using different measures. So that's great. And I think the next slide is just a little recap and we're right on time. Um, just to recap, when choosing your process measures, you want to ask, will this measure allow me to see if we are performing the tasks that my theory of change says will lead to an improvement? And then do you see the connection to the outcome measure, right? So remembering that the outcome measures captures the intent of the aim statement, while the process measure captures what's happening in the system, right? So things that people do, like it's usually tasks that actual people, or to Maggie's point, technology may be doing. And so just to keep that in mind. Oh, you're welcome, Lisa. Thank you so much for sharing the example and helping to generate some discussion around it. That's great. Okay, now we're going to be handing it over to OHT examples. And I believe John is up first also because he has to head to another meeting after this. So take it away.
Thanks, Janine, and thanks for the invite to share our experiences and learnings today. So my name is John Kwok, Project and Quality Lead for supporting Nipissing Wellness OHT. We are located in Northeastern Ontario, so for more context, in the North Bay, Sturgeon, Mattawa area. I know that cohorts are becoming less of a thing due to kind of provincial direction, but we're technically cohort 1. And of note, we're also involved as one of the group of 7 OHTs in the home care modernization leading project work, and one of the initial 12 in the OHT acceleration work. Next slide, please. So I think we were invited to kind of share today because we've got either unique situation or unique perspective or interpretation of some things. So starting off with this example, area of focus in the improving overall access to care in the most appropriate setting. Our target population for this initiative was older adults in the community who are at risk for hospitalization, significant decline, or ALC. This was chosen because ALC for a long time has been one of our top priorities, continues to be a huge issue in our district. And we'll get into how and why in a little bit, but the objective of this change idea was to implement upstream management and or avoid ALC risk altogether. And so how we are doing that is participants are referred to our SMILE program. So that stands for Seniors Managing Independent Living Easily, which is a program run in conjunction with our partners at VON. And so individuals referred to this program will receive non-traditional supports, such as homemaking, grocery shopping, transportation to appointments, etc. And even those who may not be a great fit for the program will at minimum receive some assistance with service navigation. Next slide, please. So in terms of measures, starting in fiscal 23-24, our first intent was to measure the percentage of inpatient days, so program participants who spent time as an inpatient, but also had finished their acute phase of care, but was still occupying an acute care bed. So basically looking at the percentage of program participants who ended up ALC. We also looked at those unnecessary ED visits and the percentage of ALC home days. So this is where we start to kind of diverge a little bit. The other day, even Janine came to me and asked, what does ALC home days mean? Well, the answer is our system is so backed up that we've created measures to look at individuals who should be able to go home or should be able to go to LTC, but still are taking up an acute care bed. So that would be our ALC home measure and our ALC LTC measure. So that's what we started out looking to measure. Flipping over to 24-25 fiscal, wouldn't say that we did a fully scoped PDSA, but we did kind of have a review process there. And you'll notice that some of those ideas and measures are either removed or adjusted. So that first measure, we shortened to just percentage of inpatient days from that program population, with the rationale that it was just simply easier to measure. And we also felt like the ALC component would be captured below with the number of ALC home days. So in short, we took the total number of clients in the program, so 410, multiplied by an average length of stay of about 40 days. And so we got last year 16,236 days, which represents days in which people should have been home but still occupied an acute care bed. So that's kind of our first example of a unique situation and how we kind of manage that. I think if we've got a second example coming, so if anybody has any questions, we'll kind of take that now.
Any questions for John about their ALC example in the SMILE program? Okay, I
Not
think you
seeing
can
anything
continue,
immediately.
John. Yeah, or people
Perfect.
can type them in the chat. Yeah.
Yeah, and then I'll share my email at the end as well. So, so the second example we wanted to share, this you might recognize this as one of the suggested areas of focus and measures. So, increasing overall access to community mental health and addiction services. Our target population was just those who access ED as the first point of contact for MHA care. So again, our uniqueness comes from the fact that in our district, access to MHA services in the community is quite sparse. So at this point, all we're looking to do is establish a baseline in terms of total access to care volumes. Another reason for that is coming down the road, we know that there is going to be a regional strategy in the Northeast that will develop this strategy in more detail. So for now, we were just looking to kind of get baseline numbers. Next slide, please. So starting off, again, seems pretty straightforward. We're just looking for those who use the ED as their first contact. Other facilitating measures, number of new intakes, number of new patients, number of care-related sessions. So again, where we start to diverge is because we have such a lack of other access points to these services, we've actually flipped the performance measure direction on its head. So what was recommended is, you want to have a lower measure because that represents people accessing care in community. Well, we don't have those. So for us, we're interpreting this as an increase in people accessing care is positive because accessing care, period, is the net outcome. It's still net positive. So yeah, just wanting to share kind of a unique take on how to use the measure and how to use the performance direction on that one. So those are the two examples we wanted to share. I saw some things in the chat here we can try and get to.
Yeah, that's great, John. Yeah, I think there's a question about your measures. And yeah, Maggie just is noting that including the context is great because so I think what you're saying, John, for you is it's a positive outcome if someone comes to the ED seeking help because it's in the ED where they can actually get connected to these other services like group or individual types of sessions for mental health and addictions, and there's no other door for them to go through. Is that correct?
So, yeah, so even simpler, accessing care is better than not accessing care. So that's kind of where we're at.
Yeah. Excellent. Any other questions for John?
And then if we flip to the very last slide, my email and our website are there for anyone interested.
Excellent. Well, you have some positive comments in the chat, John. Thank you so much for taking the time.
Perfect. Thanks, everyone.
Thank you. And I think we're going to, I'm not sure, Melissa. Emily, yes, we're going to Emily next.
Perfect, thank you. So hi everyone, my name is Emily. I'm the manager of integrated health systems at William Osler, and I hold a dual role with the Central West OHT as the team secretariat team is what we call it, the team manager. So if we go to the next slide, please. So my example today is specific to the PAP test. So with our cQIP work, when we had launched it back in 2021, with the preventative screening work, we hyper-focused on one area. So I'm just going to provide some context, and then we'll get into the details about why we did that. But what you'll see here, just to set the context, is that when we were first introduced to this work, the first thing we did was let's understand what our screening rates are in our region. And as you can see here, our region, we are in Brampton, we're in Malton, Northwest, or North Etobicoke and West Woodbridge. So we crossed a bunch of boundaries, but we wanted to understand across all of the preventive screen indicators, where were we doing the worst and where were we doing the best, and let's hyper focus. So in January to March, you can see here that we're doing, for the PAP test, we were doing kind of okay, but not the best in a lot of areas. And you can start to see pockets like the Malton, L4T, North Etobicoke, which is M9V. It was kind of like on the cusp of not the best screening rate. So if we go to the next slide, that being said, you can see how in September 2021, post the initial wave of COVID, there were certain areas circled here on the slide where it actually, our screening rates got significantly worse. So that's where we made the decision, let's focus on PAP tests, and some really great background information as well from Maggie and Janine. But in order for us to move that big dot indicator, we wanted to narrow down our focus. So if we go to the next slide, please. So with this, we developed our current state narrative. So in addition to cervical cancer screening being the most impacted by COVID, because that's the one where it was cervical cancer is typically screened in primary care. A lot of primary care went to virtual, which impacted a lot of these types of preventive screening appointments. Meanwhile, some of the colorectal, which can be done, the initial screening can be done at home, or the mammograms, which is typically in acute care or in the community. This was heavily impacted, especially in those underserved pockets. Unfortunately, we also have one of the lowest cancer screening rates in the province. And you can see here that specifically overall, our rate for cervical screening actually significantly reduced during COVID. And there's also inconsistencies in measuring across different healthcare organizations. So we learned in our process that, for example, a community health center, they have a different definition of when screening happens for cervical cancer versus perhaps primary care. And we are a very diverse population, and we found that there are many barriers for why people are under-screened, whether it's structural access, cultural, religious, and socioeconomic barriers. So one thing to note too is those 4 pockets that we highlighted in the screen previously. For example, we don't have as many primary care providers in those regions versus other parts. So with the goal of trying to move that big indicator, which is that overall screening rate, we decided to first define our population, and we kept it very broad, and we've kept it very broad for specific reasons, but focusing on under-screened women. But we wanted to narrow down our focus to those 4 postal codes because they were the most impacted by the decrease in screening rates. And that's where we came up with our change idea. So we recognize that before we start to actually make an impact and increase our screening rates, we do need to collect better data, to be honest. And that was some work we did around creating a baseline in terms of the data that we collect, but also consistencies across definitions for screening. And then from there, trying to set up pop-up PAP clinics, depending on whether that's in a mobile form or getting people into the clinics. That was our goal, especially besides just screening, but making sure there was a contingency plan along the continuum so that if someone comes back positive, we have a plan in place for them to receive the care that they need to move forward with next steps. So when we were doing this work, we narrowed down our process measures. So what were we going to measure so that we can understand how we're contributing towards the change in the big dot? So the first thing we did was we wanted to collect the number of sites that use the standardized data collection template. So if we go back to the All Nations example, I think just a reflection as well, some process measures may be more specific and narrowed down versus some others may be a little more high level. And we did see this as more of a high level process measure, but it was important for us to try to meet our target across our partners who had agreed to do this work, who's going to start using this template and who's going to start collecting standardized data. In addition to that, because we were doing pop-up type clinics, we wanted to understand how many people attended education events. And from there created a process metric around percentage of women screened. So looking at the number who attended an education event and then the number of people who were screened so that we could come up with the percentage of women screened. So if we go to the next slide, please. I know when we were preparing for this community practice, there was also a question around other process metrics that we're using for our other areas also for this year. So the type of metrics for preventive screening worked well. So it is something that we want to try to roll over some of those metrics. But you'll see here for other examples like the mental health and addictions, and also ALC, we're trying to refine our metrics around those as well. And there's some examples on this slide here. But I'm happy to answer any questions. And if anyone's ever interested in our outcomes for the preventive screening, we had some really great outcomes in terms of increasing our screening in those postal codes. So I'm happy to share those as well. Thank you. Oh, and on the next slide is my contact information and our website. Thank you.
Amazing, Emily. Any questions or comments for Emily? Sarah, I see your hand.
Hi, Emily. Thank you for your presentation. I was just wondering, did the OHT design the data collection template, or did you co-design with maybe your regional cancer program? How did you go about trying to get that data?
Yeah, that's a great question. So we fall within the Mississauga Halton Regional Cancer Program. So I know some of my colleagues like Sarah from Halton are on the line and we meet with that group quarterly now. When we were doing this work, actually, the initial data we did not leverage any data from the regional cancer program. We used census data and then also data we had access to for screening rates across the different FSAs. But the standardized data template, we actually were lucky enough to have a consultant work with us. And she worked specifically with the two participating community health centers. And once we got through the initial review of their data, came up with a standardized data definition, then the consultant actually helped us create the data template. Does that answer your question?
Yes, it does. Thank you.
Thanks.
You're welcome.
Thanks, Emily. And I'm not sure if these are things that could be shared additionally on our cQIP COP, but I can connect with you after and see what you're willing to share with the rest of the partners afterwards. That's great. Okay, amazing. Well, if you have further questions, please put them in the chat. And I think, Emily, you can monitor the chat maybe after to see if there's any other questions and follow up. And thank you so much. It looks like amazing work. I'm excited to hear that the change ideas are working and your outcome measures moving in the right direction. So that's great. And we'll move on to our next speaker today, Melissa. which is Kate.
Okay, thanks everyone. So my name is Kate Pataki and I'm the Population Health and Quality Improvement Specialist with the Chatham-Kent, Ontario Health Team. And I'll also be chatting about our cervical cancer screening change initiative and some of the process measures and I'll even kind of dive into a little bit our process around how we select those indicators and even some changes that we have made since kind of standing up this project. So next slide, please. So just a quick 101 about CK. We are very southwest in Ontario, and we are kind of sandwiched between Sarnia, Windsor, and London. And we have a lot of rural urban areas, mostly rural though. Our urban areas are very small still. So our attributed population is about 105,000 patients, and approximately about 20% of those patients do not have a primary care provider. So we have obviously some inequities in being able to access cervical cancer screening. So we do have another unique aspect of Chatham-Kent is that we have 4 primary care teams. Sorry, that's supposed to say 3 family health teams and 1 CHC, where all of our primary care providers are most of them in our area are connected to a primary care team. So we have lots of allied health. There are less than 5 solo primary care providers, and I think it might even be hinging on 0 due to some recent retirements in our community. So our amount of solo physicians in primary care is very, very low. Next slide, please. So where we started with our cervical cancer screening, where a lot of other folks start, is with the data. What are the subpopulations who are driving, maybe lower screening rates? For us, we kind of knew we had a hypothesis that it would be our unattached population, and the HSPN data, I think, confirms that, where we see those who are not rostered with higher rates of those who are rostered to a primary care provider for cervical cancer screening. So obviously this subpopulation faces a unique barrier in not having a primary care provider, because you need that PCP in order to access the cervical cancer screening. Next slide, please. So what the change initiative that came about was essentially the 4 primary care teams, the 3 FITs and the CHC, came together to implement a monthly PAP clinic for patients who are not attached to a primary care provider and providing that access. So each team takes a month and hosts the clinic on a rotating schedule throughout the year, as well as, given their offices are spread across Chatham-Kent, we are able to put them into the rural areas as well as some of the urban areas as well to further increase that access. So essentially what happens is a patient who are not attached can call to schedule an appointment, and nurse practitioner at the various dates and times offered throughout Chatham-Kent, and they can kind of select a town or time or date that works for them. Essentially, the NP would conduct those cervical cancer screening when the patient attends, and they would be doing the follow-up with any results requiring referrals. And then we have a good working relationship with our local OBGYN, and anyone who needs further care would be referred on to them. So really the aim is to increase our cervical cancer screening rates in the subpopulation of those who are unattached to primary care, and essentially in contributing to the overall goal of increasing overall cervical cancer screening for the OHT. Next slide, please. So Janine and Maggie provided us with some education. One of the pieces that they mentioned was a driver diagram. We use the logic model, very similar ways of thinking of things. I feel like the logic model is kind of flipped just in the way of thinking through things, but just another way to map out your project activities to your process measures to your outcome measures. So as you can kind of see, there's 3 main activities with this change initiative: patient scheduling, PAP appointment, or essentially attending the clinic, and then the follow-up and referral. So, and as you can see, there are several process measures that can capture each of the aspects or each of the activities to understand what is happening with those activities. So number of clinics hosted per year, number of patients scheduled, number of patients scheduled by specific locations in Chatham-Kent, number of patient no-show at scheduled appointments, number of patients receiving the PAP test, and then number of referrals sent based on the PAP test results. So all of these process measures, if we look at them, should help tell the story of what's happening in our change initiative. And then we'll hopefully, if we're seeing good process measures, we should then theoretically see our outcome measures increase, which is, as I mentioned, our aim statement, as well as increasing the percentage of early identification of cervical cancer. Next slide, please. So the process measures, we obviously don't have all of these on our cQIP, and we have partnered with our primary care partners to help provide this data to us and share it amongst our kind of QI group that we have. So the CHC is the one who schedules all the appointments and sends the patient lists and appointment times to the primary care team who is hosting that month. And then each primary care team then reports on the number of patients who received the PAP test and number of no-shows, number of patients who completed, et cetera. So they're kind of the owners of that. And I kind of put the bottom one in a different color, or I tried to, it looks very similar to the title one, but we were also collecting on the number of referrals sent based on the PAP test results. So if a test came back and it was flagged that further investigation or further referral needed to happen, we were collecting that at one point. However, it became very difficult to track given that there was such a lag in time of receiving labs back. And also it was very varied. So it would require a lot of digging for the NPs to go back and look into charts and things like that. It became more of a goose chase and a headache. It also still didn't, it's important for cancer care, absolutely, but it doesn't really contribute to the aim. So we decided to just kind of shelf that one for now until things maybe get a little bit easier, or if we change our processes. So that's kind of the layout upon how we're collecting those process measures and things like that. Next slide. So the ones we did select were, we honestly picked the easiest ones to put on the cQIP. They're the easiest one, but they also help explain what is happening for our change initiative and provide that good sense of a summary. So the process measures we selected were the number of clinics hosted or scheduled, which we, and then the second one was number of patients to receive a PAP test through those monthly PAP clinics. I started putting a date on mine in the cQIP because it always takes time to get approvals and submissions and things like that. So just for ease, that's how we kind of put that. So then it makes it a little bit easier, especially if your last one is in March, but it's like March 20th. And then we attached some targets to it. So we're going to have 12 hosted or scheduled, so we can capture that March one if it's scheduled. And then we are going to put out to 80 patients and constantly looking at the other process measures to see how we can continue to improve. So those are the ones that we do have on our cQIP, and that's kind of the thought process that we went into selecting them. Next slide. I think it's okay. Yes. And so that's essentially all of that in a quick presentation. I just want to let everyone know that we will be restructuring our website. So all of that information will hopefully be up on our about our cQIP, like our work plan, et cetera, will be available soon, hopefully by the end of summer. So if you want to take a further look, but if you have any, in the meantime, have any other questions or would like to inquire more about the work that we're doing, I'm happy to help with that. So you can just send me an email.
Great. Amazing. Amazing presentation. Thanks for connecting it back to the theory, Kate, and the cQIP. That's wonderful. We have a couple questions for you in the chat. One being, how did you resource the MP? Was it in kind?
Yes, so it's all in kind. We have not received any funding for that. And what it typically looks like, so there's 4 teams. So if you're thinking about you're doing it maybe once a quarter, sometimes they switch things around and depending on what things like that. And then the NP will just kind of block a day off in their calendar. And then once they get all those kind of patients put in, then they will fill them into 30-minute appointments, I think. I think what happens if the clinic doesn't fill, because it often happens, especially in like our smaller towns, we're kind of struggling. For instance, Dresden has like 2,000 residents living there. So it's obviously just a smaller center, I guess. So if they aren't able to fill it, then they just use those blank appointment spaces as urgent care for the day. So then the team can still optimize the NP and still provide care, but still providing that space for the PAP clinics. But yes, all in kind. And we've been very lucky to leverage our OBGYN folks in Chatham-Kent to be able to refer those patients on, given that they don't have a primary care provider.
That's excellent, Kate. And I think you had some data which provided a very sort of likely a motivating narrative, right, for the teams to go, oh, hey, we should probably do something about this, and that might have made it easier for you to get the traction. Yeah,
absolutely.
Thanks. The other question is, any thoughts or expectation of what the number of positive PAP results requiring follow-up might be? Do you know what proportion we're requiring full follow-up?
So I believe, so when we first, so this isn't the first year we've done this. And we're just trying to continue to improve it. So we keep it on our cQIP. It is, I would say, it's not a very technical term, but there's a couple every once in a while, I would say. So if there's 12 appointments in one clinic, I would say every other I don't know why my hand's up. Every other clinic has probably 1 to 2. Sometimes though we went for like without any. So it's very varied, but there definitely were some that were flagged as needing follow-up. So it was an important piece. That work still happens. We're just not tracking it as closely given like the reasons I had mentioned. So very important, I think, aspect of the whole change initiative to continue on with that cancer care.
Thank you. Great. Okay, well, I'm sure there's only a few minutes left. I'm going to start a wrap up, but if you have a few last questions for Kate, you can, I think, put them in the chat now, and she might be able to answer them. We also have our cQIP shared space. We're going to do the post knowledge test and then point you guys in the direction of some more QI resources. So Melissa, if you can, so it's this, the first one is the same question from the beginning. So now that you've heard all of this, do you feel that maybe your answer is going to change? If it's the same, that's okay. But now after the session, do you understand what the process measures are and how to use and apply them? Would you still say but you're not sure how to use and apply them? Or would you still say no clue? And then our second question, we do this just to kind of monitor if we're meeting the group's needs. So how likely are you to use one idea or concept that was discussed or presented during the meeting today? And you can choose from extremely likely to not very likely at all. And then I'm gonna so maybe we can go to the next slide. I don't know if you're able to move slides while you're still running the poll, Melissa. Yeah, and the next slide. So there are several of these tools that we talked about today and information about the model for improvement, QI science, driver diagram. They're all available on Quorum. For this public page, you don't need to be like a member like you do to join a group. So I've put the link in the chat. You guys can go there, take a look. If you have questions about any of these QI tools or methods, please reach out, post your questions on our cQIP shared space. or reach out to Maggie and I, as we can help a little bit with those things. And oh, that's great. Maggie's noted. Yeah, if you need access to the OHT data dashboard, we're going to post the deck, and the appendix of this deck has information on other tools and resources that people can access. And I think we can, is the poll closed now, Melissa? Can we close the poll? And I think that's sort of a wrap up for us. Do we have any other slides? Yeah, don't forget to join our cQIP community practice. Make sure you subscribe, because then if new stuff gets posted, you'll get it directly to your email inbox. So that's important. And Maggie, have I missed anything?
Sorry, sorry, I was just typing a response to Samia. No, I think we're gonna, so the recording and the slides, we're gonna put in the COP. I don't, does it automatically, do we automatically send it to attendees?
No, we
Melissa,
don't
I don't
email
know.
it out.
Okay.
You'll go to the shared space to grab the stuff, and the recording will be added to our YouTube channel. I believe the link's in the description of on our shared space group. If not, I'm going to add it in there. So every time we hold a session, we record it and add it to our unlisted YouTube channel, so you can go back and see the ones you've missed as well.
And share it with your partners if they're interested.
Yeah. Thanks so much to our OHT peer presenters today.
Thank you.
It was really great to hear from you. Thanks everybody for taking the time to join us and learn a little bit more about the family of measures. We'll see you again in the fall, when we're probably going to talk about collaboration. So leveraging collaborations in your cQIP. And I'm wishing everybody a great day. Thanks so much.
Thanks, everybody.
Thank you.